Welcome, everybody. I'm Dr. Howard Koh, the Feinberg Professor here at the Harvard Chan School of Public Health. It's my great honor to welcome you to this studio event entitled Housing and Homelessness, Solutions at the Intersection of Public Health and Public Safety. We're just delighted to see all of you to discuss the very challenging crisis of homelessness that we're seeing across the country, but also focus on solutions that are multidisciplinary and cross-sector. And we are so thrilled to focus on solutions because we have an all-star panel here that's thought about these issues from public health, public safety, housing, also from the vantage point of people with lived experience. So this is going to be quite a fascinating panel that we're going to have here for the next 45 minutes. I am absolutely honored to introduce my distinguished colleagues on the panel. So to my immediate right, Gil Kerlikowske, who's had an astonishing career in public service. He's the former national drug czar under President Obama. He's the former police chief in 4 U.S. cities, including and especially Seattle. He's the former U.S. Commissioner for Customs and Border Protection, so the list goes on and on. Monica Burrell, my dear colleague in public health, she is the global lead for public health at Google and the former Commissioner of Public Health here in Massachusetts. Leslie Creedle is an advocate and founder and executive director of a very esteemed nonprofit group called Justice for Housing in Boston. And my dear colleague Peter Katouzian, who is Sheriff of Middlesex County, Massachusetts. He's also a former state representative and the former chair of the Healthcare Committee and the Public Health Committee in the State House. So a big round of applause for this panel. So let's start by looking at the big picture nationally. And Gil and Monica, I'd like for you to start. From the big picture point of view, why do homelessness and affordable housing represent both a crisis but also an opportunity for cross-sector solutions, particularly with respect to public health and public safety? Gil, you want to start?
Sure. I think the important part is exactly what you mentioned, the cross-sector. We have found that we work in silos way too much. And so you need a public health director, whether it's at the state level or the county level, that said, look, I'm not the only person that owns this issue. They have to be willing to cede to other organizations. And you need a sheriff or a police chief that said, look, I don't need to sit at the head of the table. I need to be involved with these projects and I need to be supportive of them. And when you have those kinds of relationships, you actually see, as we know, some development and progress in this area.
You've been involved in areas like diversion and prevention. You want to say just a little bit more about those themes?
I think that Seattle in particular, the 9 years that I was chief, was particularly a difficult time with homelessness. And so people that were being arrested for minor drug crimes were instead being moved to being diverted into treatment. The other part, of course, is understanding that when people are housed, it is safer for them and it's better for the community.
Right. Okay. Excellent points. Monica?
Yeah, thanks, Gil. Just building on that a little bit, and what is the health piece of this cross-sector, multidisciplinary approach to housing and homelessness? We know that stable housing is good for our health, right? So when individuals are housed stably, our chronic diseases are easier to manage. We're less likely to get new diseases that we get from exposure on the streets, and we're able to get the treatment we need. So from my many years at Boston Healthcare for the Homeless program, I saw firsthand that when someone is staying outside on the streets or in the shelter system, it's simply harder to take care of our chronic diseases. If you have diabetes, if there's no place to refrigerate your insulin, it's hard to get nutritious food. Right? If you have an acute issue, it's very hard to get access to care. And we end up then accessing care through high-cost areas like the emergency room. And in places like the emergency room, it's really hard to do the preventive and the chronic disease management that we need to. So emergency rooms and jails are both expensive places, right? And from a societal point of view, those are high-cost places to get care. as we think about the health perspective. And we know from our prior experiences across this table that we cannot spend our way out of this, right? So when we think about cross-sector, how do we think about the way in which we can use that to address the core issues, and really with this focus on housing is health. And just to give you a short example, Howard, when I was commissioner at the Department of Public Health, we were addressing the overdose epidemic of the time, and with the goal of decreasing overdose deaths. And we brought together in Massachusetts, for the first time in Massachusetts, we built a public health data warehouse, and we used that to say, let's understand in a cross-sector way who are these individuals who are impacted by these overdoses so that we can really target our efforts in practical cross-sector ways. So some of the data that the sheriff knows well, because it led to a really deep and fruitful collaboration across public health and public sector. So just to give you an example, we found, by the way, by bringing together for the first time criminal justice data, medical data, behavioral health data, and so forth across the state, that in Massachusetts at the time, if somebody was released from a jail or prison and they had a substance use disorder, they were 120 times more likely to die of an overdose than others in Massachusetts. And we found out, most importantly for our interventions and work, that within the first month after that release is when they were at highest risk. So pieces of information like this, together with the narrative of the individuals, really help us to think from there, how do we move towards solutions?
Thanks so much, Monica. So let's ground this conversation now at the very personal level. So Leslie, you're not only an advocate and a very well-respected executive director of a nonprofit, you've had firsthand experience being incarcerated, being released, going through reentry and rebuilding your life. Can you tell us more about what that was like, and what do you wish more people could understand about this whole process for people who are coming out of incarceration?
Thank you, and thank you for having me. I would like people to understand that they say when you get sentenced and you do your time, you pay your dues, right? But it's not the case. When you reenter, society doesn't see it that way. There are a lot of biases, a lot of discrimination, so really your sentence is like a life sentence, right? It's very hard for us as formerly incarcerated people to obtain stable housing or obtain employment. There are also, I can say, collateral consequences. For example, children. A lot of our children are in foster care due to parental incarceration. 65% of parents who are incarcerated have a child in foster care. And for Department of Child Family Services, for them to reunite that family, they require stable housing. And otherwise, that child will age out of foster care, and then the cycle repeats itself over and over again. 1 in 3 children are incarcerated after aging out of foster care. So you can understand where I'm saying. So in order for reentry success, for folks to be successful, have a successful reentry, I discovered housing was key, because I was a homeowner. I had a successful reentry where my peers were stuck in the halfway house for 1 or 2 years. I went home in 1 month. And so the disparities are very different when you have a home versus not having a home. You're more likely to succeed on probation and parole and things like that. And so we work very closely with DCF. Once I founded Justice for Housing for that reason, because there was no housing when I was released. The barriers were there. Housing authorities and landlords didn't want to house formerly incarcerated people. Massachusetts is supposed to be a progressive state, and everybody's like, oh, everybody deserves a second chance. But when you want to move next door to somebody, that goes out the window, right? Oh, I don't want them in my neighborhood. And so there's a lot of, hypocrisy and biases.
I've heard you tell your story before, Leslie. It's so moving. And what strikes me every time I hear you speak is you talk about your experience not with bitterness or anger, but resolve to make something positive out of it. I've also heard you talk about the support of your family when you came out of incarceration. That meant a lot. You want to say more about any of those themes?
Sure. I was fortunate. My daughter was, I think, 18 when I went to prison, and she had to drop out of college and get 2 jobs to maintain my household because I was a homeowner, and her girlfriends rented rooms, and that's how they were able to maintain my house. And so founding Justice for Housing in her memory, a year before I was released, she was killed by gun violence. And so that's why I do this work, is mainly in her name, because without her, able to maintain my house, I would have been homeless. What 18-year-old is able to maintain a mortgage and pay the electric bill? And, Brianna was very mature, and I was very proud of her.
Thank you, Leslie. It's so moving. So, Sheriff Peter, let's talk a little bit more about public safety and prevention, a topic that doesn't get enough attention in the country right now. And I'd like you and Gil to respond to this question. How can homelessness and related health issues be approached with partnership and prevention rather than arrest and punishment?
Effectively is the word that I would use there, okay. Howard. As you know, Howard, I cut my teeth doing public health and health care in the legislature,
right.
While you were our commissioner, and moved on to greater and more important and powerful things that you did. And that was a great training ground to become involved in law enforcement. I take a look at I address public safety issues through a public health lens. We should understand that the same social determinants of health are the social determinants of incarceration. And the impacts on families, as Leslie was speaking, are really powerful. I thought of a few different ways that the idea of the tipping points, and I think as Gil said, and we can speak more about this, is the fact is getting good partners from the public safety communities involved earlier in the process to help resolve that. Because we don't want to have to process, for many of these people, especially those that are struggling with substance use and mental illness, which is a significantly larger part of our population than ever before, that time of incarceration can exacerbate matters. And I'm really proud of the programs we run at the Middlesex Jail and House of Corrections. I really don't think you'll find a more robust, programmatic, data-driven, innovative operation in the entire country. But you shouldn't have to come to jail to get good programming. You should be able to get those in the community so you never have to become justice involved, and then maybe to the point of incarceration. But there are a few tipping points that I just took note of that I wanted to mention after Leslie had mentioned that, because I think it's really important, is the impacts on the family. Leslie was really fortunate to have a family and a foundation that she could go back to. A lot of our folks don't have that, especially the women. They have less of that than even the men. It's a very different. Cycle of incarceration and experience, and 5 times more likely to be primary caregivers of children. Just a whole different world, and it's harder for them to come back out than even the men. But there's a few points of 4 key tipping points dealing with incarceration and homelessness, or those that are incarcerated. And one is the devastating effect of incarceration, because formerly incarcerated people are 10 times more likely than the general population to end up homeless, right? Or experiencing homelessness or insecurity. Substance use and mental health individuals preparing to reenter, as Monica had mentioned, 120 times more likely to die as a result of an overdose. We actually are bending that trend because we're doing medication-assisted treatment in all our facilities in Massachusetts.
Wow.
Very cutting edge for the country. So I believe that I know in our study that we published, we're bending that trend downward. estrangement from family and support networks, as Leslie has spoken about, and then people become homeless for financial reasons, and then having that loved one that's incarcerated, we forget about the impact on their families, and the social impact, as Leslie described, the financial impact, and quite honestly, then the impact on the children of those families, which then have higher rates of justice involvement, failures in education, truancies, engagement in the justice system, and higher rates of incarceration. So I call it trickle-down corrections. If we can stop it in one generation, then we can save many generations thereafter as well.
That's great, Peter. Gil, you want to add?
Yeah, so I think homelessness for a police chief is filled with political traps. So many mayors look to the police department to solve problems, mental health problems, addiction problems, etc. And they say, look, you know, you've got the biggest budget out of anybody else in the city, and you've got an easy-to-remember phone number. So, you know, we'd like you to take this on. So if you're in a city like Seattle, you know, you've got progressive groups that say, well, wait, we're going to allow tents on our church property. And you have other progressive groups that say, well, we're going to bring food to different people, you know, wherever they happen to be. And then you've got not in my backyard people, homeowner associations, et cetera. And you've got all this mix on your city council all telling you, well, we can't have this going on, and we can't have that. And then in some of these homeless encampments, you have violence, and you have drug use, etc. So here you are as a police chief trying to say, you know what, I should be smarter and not take this on by myself. I need allies. I need people not only in public health, but I need people within the mayor's office, policy groups, etc., to work on this. There is no easy answer.
I'm just wondering, this is a public health audience, and how many health professionals naturally partner with sheriffs or police chiefs? I hope the numbers are growing. Maybe you both can just say a little bit more about that.
I mean, I will say that in Massachusetts it is far more than elsewhere across the country. I mean, Massachusetts, the state that invented co-responders, community policing. You know, these are programs that have been running for decades now in Massachusetts and have shown incredible benefit. So when you go around the rest of the country, you don't see programs. You might see them in a city or town, a progressive city or town around the country, around the rest of the country, but you don't see them statewide like you do right here in Massachusetts. Yeah. We're not as good as we should be, but we're far better than most.
But the difficulty is also that, like in a city like Seattle, you don't have a health department. It is the King County Health Department. And so they serve a lot of other jurisdictions. So the city of Seattle said, you know what, we're going to add $50,000 more to that county health program because we want some additional services for people. Well, then, when you talk to people at the Salvation Army and other places, you find that because you have these additional services, that you're finding people being attracted to the city for those kinds of services when in fact they're coming from either nearby suburban areas or even from out of state. So on the one hand, you've got a group saying, we need to do more and let's put more money into this. And then the other hand, you're saying, well, wait, are we making this too attractive? Difficult.
And Howard, if I could just say one thing, I used a term that I'm not sure everyone's familiar with. Community policing, most people know. It's where we engage with the community. It's the old Peelian principles, right? We're actually like, working with our communities. The other co-responder, which many people might not understand, which is where you have social workers or licensed clinical social workers that will actually go out on police calls for matters that may otherwise be criminal behaviors, but don't necessarily have to be treated in the end like criminal behaviors if you have the right supports. So police are much more skilled, as Gil will testify, in de-escalation. But the idea of having a licensed clinical social worker going out to a home where there is a conflict, often involving mental illness, often involving a domestic, that is otherwise unresolvable unless the police make that arrest, to have a social worker out there with them to then find the resources to divert that individual to, can avoid that arrest, create that diversion that we need pre-arrest, avoid that incarceration, and get them back on the track that they needed without having to go through the problematic parts of the carceral and our justice system.
Yeah, I'd rather have two social workers in a Prius wearing T-shirts, responding to certain calls that are carefully screened, responding rather than a police officer, because it doesn't matter how well trained the police officer is, when they show up in that marked car in that uniform, all the barriers go up, and it used to be that even President Biden would say, well, they have to be paired with a police officer, because of the hazards. And that's not true. They're so skillful at de-escalating situations because of their work as a clinician.
That's fascinating. Fascinating. Thank you for all those concrete examples. So let's talk more about long-term solutions, because it's too easy to focus on the short-term crisis. So Monica and Leslie, can you both comment on what public health principles should guide responses toward long-term stabilization and better health outcomes in the long term?
You start.
For us, we created a program, Stable Housing and Reintegration Program. We call it SHARP for short. And what it is, it's housing plus wraparound services. And so it ends up being like an 18-month program where individuals receive a housing voucher. We partner with housing authorities, and in order to get them stabilized, we put them in our reentry house first, and then we work on the wellness, work on healing, getting them to learn how do you put your cable on, how do you get your ID, you've been in jail for 30, 40 years. Some people have been in there that long. I had one guy tell me, when I went to jail, there were rotary phones. Now the phones are talking to me. So, little things like that people take for granted, right? But it's really hard when you come home from prison. Computer skills, all of that is gone. And so once, you put somebody in an apartment, you can't just leave them when they've been in prison for 20, 30 years. You have to case manage, you have to do site visits, and help them get acclimated, help them get employment. And so that's what we do at Justice for Housing. We partner with other organizations and provide the wraparound services. It's been, we have a 2% recidivism rate versus the state's 26 recidivism rate. And last year, we had our first homeowner. We had someone give back.
That's great.
Yeah,
That's great.
thank you.
That's great.
After, because a lot of people, some people don't like people living on social services. Like, okay, you get Section 8 voucher. It's, they help pay your rent. They don't pay it all, but they help. But I think it is necessary for somebody who's coming out of prison. One, because they don't have employment yet. In order for them to get employed, they need to be stable. And so once they're stable, then you can focus on your employment, focus on reuniting with your family members, your children, getting your kids back. And that's what SHARP does. And then after that big picture, and they're stable, we try to get people to become homeowners, because we're Justice for Housing. So we want people to be homeowners.
That's fantastic. Yeah, in the field, we often talk about supportive housing, and that's what you're talking about, the wraparound services. And,
But making it permanent housing, right? Making it stabilized so you can have wealth, generational wealth, equity, something to pass down to your kids.
That's great.
So yeah, it works.
Great. Monica, you want to say more?
Yeah, I think Leslie's raising this point is, as you mentioned, most of our audience is public health. And in public health, we try and take a step back and say we are addressing lots of complex public health issues, and what are the root causes of these, so we can address those cross-sector. And when we think about, and this has come up in this discussion so far, when we think about what are the causes of somebody having an experience with homelessness, right? They are multifactorial, and not all of them are related to health. So they are financial, they are related to medical bankruptcy, related to chronic diseases and illnesses. They are related to undertreated or not treated mental health issues or substance use issues. They are related, Leslie brought up, and the sheriff brought on it too, this issue about children. And having an experience of homelessness is directly tied to adverse childhood events, right? So the cyclical nature of things. So all of those and others lead to an experience with being homeless. And when we have an experience of being homeless, right, you could say, well, how do we address this? One of the most important things are, if somebody falls into that, how do we quickly get them out and not into a recurrent cycle? Because the longer that someone's in that, right, and you've heard these terms of chronic homelessness, when someone's longer term experiencing homelessness, and that's actually not the vast majority, it's a minority of individuals, but they're the individuals who then it's hardest to help them exit because of not only their chronic diseases or their mental health and substance use issues, but new illnesses and because of this inability to prevent disease or to do protective or services. So when you think about the causes and the etiologies of these cycles, in public health, if we say, I know we're not saying that, but if we say we alone have the answer to this, how can that be when the etiologies are far outside of our lane, right? So there's this concept of stay in your lane that people talk about. And for the students here, please stay in your lane to become educated and to learn your field as deeply and as knowledgeably as you can, and then shift lanes frequently, right? And understand the perspectives of those outside of our fields, because it's only if we in public health say, well, all that public safety does, is use force, right? Or if in public safety they say, well, these, public health people are trained in disease outbreaks, and if there's a food poisoning, they can address that, but they can't understand the homeless, right? So to understand what are the things that we can work on together and how to get towards that causal piece of it, that is the cross-sector piece. And when we are only looking at our part of the solution, we're missing all of these other things that are being spoken about. And we're, Leslie, your thoughts remind me of this, concept that when one of us is out on the street looking for our next meal, trying to find a safe place to sleep, we all show survival-based behavior. There's not one of us who would not do that, right? You want to protect yourself, you want to be safe, you want to protect your children, you want to make sure you have your next meal. And so some of these things that we're talking about, there has to be support in a cross-sector way in order to allow people to be able to access these services and supports.
That's great, Monica. Let's go a little bit deeper. We always say that we want to follow evidence-based responses. So when mental illness, substance use, and homelessness overlap, for example, what's an evidence-based approach look like? And I want all of our panelists to comment. So Monica, why don't you start quickly, and then we'll have our...
He said quickly. This is a really important area, and when we look again at people who are exposed to having periods of being homeless, right? There's a lot of impact from that. And we talked about going upstream. So there, I follow a framework of thinking about this because otherwise the problem seems so large. Like, where do you start? And so for me, I have a short framework that I use. That's one is localize the problem as much as you can. And what I mean by that is whether you're thinking at the national level or the state or the city level, how can you get as close as possible to the primary people who are experiencing the issue and also the primary people who are working with them, right? How can you get as close as possible to that? And how can you get as close as possible to the primary data, right? And collecting that is about trusted voices, so community health workers, recovery coaches, right? Epidemiologists, which we don't always think about. How can you get as close as possible to deeply understand what the data is? And then step two is taking that and analyzing it in a way that is systematic and helps you understand both the individual's concern and needs and at a community level, because this will help then getting to the steps of program and policy. And then, by the way, while all of this is happening, having robust clinical services in place, because at the same time, as we spoke about earlier, all of the illnesses, right, the medical, the mental health, the substance use are still happening. So we need to get care that is empathetic and where a person is able to access those. So whether it's trust, whether it's on a street corner, whether it's in a clinic, whether it's in our criminal justice system, where a person can access that, so that as we're trying to work on this, we're actually treating their care. And then addressing the social determinants in a way that is beyond thinking about the next step, but really like, where do we think about, income possibilities, right? How do we think about nutritious meals, housing stability as we're dealing with this? And then finally, partnerships and thinking about long-term solutions while all of this is happening. So I think of it as a multi-pronged and dealing with the acute and planning for the long term at the same time.
Great. Gil, Peter, Leslie, Gil, you want to go next?
Well, these are linked, and Monica, I think, hit it succinctly about you have to meet people where they're at. And that is the key. When Seattle first went to wet housing, where people could actually use alcohol after they were off the street, there was a lot of concern. And frankly, as a police chief, I had a lot of concern about it. But when you realize that they're not going to be able to just abstain from using alcohol, but they can be in a safe location. These were stoves that would have a timer that were automatically shut off. There were all kinds of things that were put in place. And, you know, it really helped me to better understand that rather than, well, you should just lead a straight and narrow life and get a job and go back and et cetera, then you're living in La La Land. And so you have to meet them where they're at and figure out what is the practice. And lo and behold, in wet housing, people actually, during the time they're there, use less alcohol and could become better.
Thank you. Leslie or Peter?
So, for me, I would say a peer model. Also, not operating in silos. I think a collective approach, right, with corrections, lived experiences, health care workers, all work collectively, but being led by a peer, somebody who's directly affected. I think somebody closest to the problem who has experiences is the best person to support that person because of the trauma. There's so much trauma when you are coming home from incarceration, just from maybe from the experiences you had inside or experience of being homeless and formerly incarceration together. For me, I had trauma from my experiences of losing my daughter while I was locked in a cage, right? And so being in a cell and not being able to have my family there or even talk about it, right? Because we're all mothers in there. And so I was like the example of their worst fear. You know, when you're in prison, your worst fear is, I hope my kids are okay, right? And that would be my prayer every night, please take care of my kids. And so you remind them of what you don't want to happen. So when you lose a child, you remind all the women of, oh God, I hope that doesn't happen to me. And so I wasn't able to heal. I wasn't able to talk about it because of being where I was. And so when I came home, all of that came out, right? All of that healing, I healed when I got out, and it all hit me when I walked in my house and my daughter wasn't there. And so I had a lot of anger towards corrections, just because of how the whole situation, her funeral was made and all that. So I had a lot of anger, and I was just telling the sheriff, like, I didn't want to partner with them, you know. But now that I'm healed, I'm like, okay, I'm ready to partner. I'm ready to, to move on. I know how to process my grief now, and so I'm not ever healed, but I know how to process it. Put it that way, and so I think having those lived experiences, somebody like myself, is a perfect model for somebody coming out and giving them the support they need, and also working collectively because we need each other.
That's beautiful. You turned pain into power. And our initiative, by the way, is having growing interest in understanding people with lived experience and how they can be leaders and role models and connectors, everything you just talked about.
Yeah, we need health care, we need corrections, and we need lived experience. And I think that would be the perfect model.
That's great. Peter?
So, Leslie, when you speak about the pain you suffered, not only because your daughter passed, but how it was processed, does that mean because you couldn't visit her or pay respects in that way?
No, it was a funeral arrangement, like how corrections were, they weren't empathetic to what happened, and it took them a long time to have me make her funeral arrangements, and that's
something that can be handled so easily and appropriately and humanely by a correctional facility, right?
Right.
If we have someone that has a loved one that passes, it's our first hope that we might be able to get them to be able to attend not the main services, but some of the services off hours to pay those respects. It's really important for their closure to treat people with dignity on the inside as well.
Thank you.
And to let them heal, right? That's, and by the way, and then to make sure that mental health is attending to you to make sure that you're getting through that with some supports that you might need. It's important to note the types of populations that we are housing now in carceral facilities. In Massachusetts, at least, and I know this is across the country, it's a much more chronically ill population than ever before. You know, the numbers may be down, but the percentages of chronicity are up. Just to give you a few numbers, 40% have a diagnosed substance use disorder. That doesn't mean that the other 60% don't have a substance use disorder. It's not diagnosed. 54% have a diagnosed mental illness. Again, it doesn't mean the other 45% don't have it. 60% have 60% have a chronic illness ranging from asthma to cancer to psychological disorders as designated by the National Commission on Correctional Health Care. And then we actually have, on our case, 76% of our population are on our mental health watch list, just because, you know, they might have serious mental illness, or they might have sleep disorders or generalized anxiety and some issues that we should be watching, or we know they've gone through a traumatic event and we want to make sure we're watching out for them for their betterment. What's really important to note as we're speaking about these types of populations and treating them in silos or together is the fact that 70% of those with a substance use disorder also have a mental illness. So what do you deal with a mental illness? Do you deal with a substance use disorder? This has been part of the problems. The way to deal with it is with multidisciplinary teams, right? You've got to deal with them both, and you really got to deal with them both at the same time. You can't like wait for one and deal with the other. You got to deal with them both at the same time. Crucially important. One of the most important things is the handoff when people get released, to make sure they have the supports and the services. By the way, I will say something that in good corrections, reentry planning doesn't start 30 days out or 60 days out or a year out. It starts on day one of your incarceration. What were the deficits that brought you into our facility? How can we address those needs while you're with us? And then how can we turn you out? And do we turn you out into family, into a program, into sober housing, or whatever it might be? That's the critical part of what we do in good corrections. And I can tell you that there's been so many times, especially during COVID, when people were being released. We got a lot of people out, those that were more susceptible to illness, we got them out, but there were still some people that organizations were bailing quickly without notice. And we were the ones on a Friday evening calling shelters that were all filled and calling programs and trying to find them someplace to go, because grandma was the only person that they'd been in touch with, the only one that loved them still and welcomed them back in their lives, but couldn't take them back into their lives. This is what happens in good reentry, is that supportive housing. And navigators are a crucial part. I got this when I was the chairman of the Committee on Healthcare. Navigators were being used to benefit insurance companies and healthcare plans. They were new at the time. They helped. Did you make your appointment? How did it go? It lowered costs. It improved outcomes. It improved patient satisfaction. So I didn't know any better, and I just applied it to what we were doing, and it worked really well. We use the Behavioral Health Justice Initiative, BHJI, to assign navigators to those that struggle with mental health to be able to help them find housing, and that had actually increased the numbers. Last I checked, about 30% to housing. But it's those navigators that not just connect with them on the inside, they stay with them through the process and then on the outside. So they built a relationship of trust when no one else cared about them, right, Leslie? No one was coming to visit, no one was checking in on you, right? But if you had someone that cared about you and then stayed with you on the outside, you'd know to trust that individual, right?
Not only that is because, you are the caregiver, right? And so if you're locked up, you're used to caring for everybody, right? And so it's you don't have anybody because you're always the one who does it.
That's right. So just having that navigator, I think it takes that social network and turns it on its head. So many of our people leave a facility and they go to hang around with the same crowd that got them into the trouble in the first place, that were not positive role models, positive social networking network engagements. And this has at least that one person that cares about their well-being, that's always there on a call to lend them support, help, assistance in any way, and to check in on them. It at least gives them some hope that someone cares about them, and then allows them to grow actually in a positive way too. Crucially important, these navigators.
I think this transition of care that you're talking about, Sheriff, so when you're discharging someone from the hospital, on the first day you think about where they're going to go, and as you're saying, in the criminal justice system, they come in, where are they going to go after?
Right.
Because part of this is if we're releasing people to the same environment that made them sick in the first place, we shouldn't then expect to see different results.
That's right. That's right.
I've heard you say before, Sheriff, that reentry planning in your facility starts on day one.
Yeah.
But that's powerful. And then the other fact that you and your colleagues have taught us is that for people who enter your facility, 99% are out in 2 or 3 years. Is that right?
They're all going back to their communities. So, I always say if we have a window of opportunity, again, I will say this again, because it bears repeating. I'm proud of all the programs we have. I couldn't be prouder. I could crow about them all day long and our results, but the fact is you shouldn't have to come to jail. But while I have a window of opportunity to affect people's lives, it's really important that we do the very best thing that we can for them and turn them out better, stronger, more productive, and feeling respected people when they leave. A place that treated them humanely and with respect, as I was speaking with Leslie about that one engagement point. If you treat them with humanity, they'll be a safer population to manage inside that facility too, right? They'll feel like they're being treated as humans, but when they get out, they'll have a modicum of self-respect. Howard is a guy that we spoke about this often, and this is something that I have practiced for many years, even before I knew that you did it. When Howard sees a person that is homeless, that is maybe asking for money or may not be asking for money or food or whatever it is, Howard always looks at them and speaks to them and treats them with respect. That's something that I found.
Well, I've learned that from my colleagues in this room.
well,
That's if I can say.
What I found was people just feel invisible out there, and I've had a number of people that I've said, how are you doing, sir? God bless, whatever it was, to say that they really appreciate the fact that they were seen. That's something that we have to do with those that are incarcerated and those that are on the outside. By the way, these encampments are really, if you've ever been to an encampment, it's a fascinating culture in there. And it's a weirdly supportive and positive culture within that community that keeps them living sometimes in those encampments while they know there might be better, healthier opportunities. But there's a community there that they care about and that cares about them, that only if you go to a community, an encampment, will you understand this dynamic where they feel like this is their home now, and that may not be the best place, the most supportive place, but it's where they feel like is their home too.
Thank you. So many fascinating themes here. Unfortunately, we're getting to the end, so let's end with a lightning round. Quick question for you and a quick response. What is the one myth about homelessness, housing, or public safety that needs to go? And what's one solution you'd like to see scaled right now? So, Gil, you want to start with that?
So we need a hearing in front of Judge Judy, and she needs to divorce homelessness and crime. They seem to be so inextricably linked by people, and yet we know that people that are homeless are not disproportionately involved in crime.
Fascinating. Great. Monica?
People experiencing homelessness are more like us than they are unlike us. We should approach the issues with empathy and collaboration and with realistic optimism because there are solutions that work.
Thank you. Leslie?
I'd say the housing first model is not a good model. Everybody thinks housing first, housing first. Some people aren't ready. Some people just aren't ready. So I would get rid of that.
Really? Mm-hmm. Okay, that's an area where there's a lot of research and randomized trials.
Yeah, it doesn't work.
Okay. more after this discussion on that one. Okay, and Peter?
Listen, let's just understand the three largest mental health treatment providers in the entire country are LA, Rikers, and Cook County jails. We're the largest one in Middlesex County. Wow. But those with mental illness are not more criminals. They're not criminals, right? They're much more likely to be the victim of a crime or a witness to a crime than they are to be a perpetrator of a crime. And that's a myth that we really need to bust.
What a fascinating panel. Big round of applause. We covered a lot of ground here. So thank you so much for watching. And if you want to watch it again, you can go onto the Harvard YouTube channel and have a great afternoon. There's going to be a lot more discussion about this in our country going forward. So thank you so much for your time and attention.
Thank you.